Okay, everyone, I'm going backward and I'm going to record on the dysrhythmias. Since there's only a few slides on the concept of perfusion, the introduction to it, I put those in the beginning of the slide. So if you actually wanted to take notes, it's just your concept of perfusion, and then I've got the dysrhythmias right behind it. Okay, so just a review. If you've looked and listened to the other lectures, you probably have this already. Just a review. Layers of the heart. Pericardium is the fibrous tissue that encases the heart and it anchors it. Epicardium, epi is around or above, it's the entire, covers the entire heart and all the blood vessels. Your myocardium, myo meaning muscle, myocardium is the cardiac muscle that's needed for contraction. And then your endocardium, endo being within, so that's the innermost layer of the heart. Chambers and heart valves. You have two atriums and two ventricles. Right atrium receives a deoxygenated blood from the body. It comes in through the superior and inferior vena cavas and the coronary sinuses, the ones that are on the heart itself, drain. Then you have, goes through the tricuspid valve into the right atrium. Right ventricle, excuse me. This receives the deoxygenated blood from the right atrium, and it pumps this deoxygenated blood through the pulmonary valve into the pulmonary artery to the lungs to become oxygenated. This oxygenated blood comes from the lungs into the left atrium, from the pulmonary veins, goes through the mitral valve into the left ventricle. The left ventricle pumps the oxygenated blood through the aortic valve into the aorta, out to the body and to the coronary arteries. This is just another picture talking about the circulation. You have systemic circulation, which is the pressure, high pressure system of the left side of the heart, aorta and its branches, peripheral tissue, systemic venous system, vena cava. Pulmonary circulation, which is from the right side of the heart, pulmonary artery, pulmonary capillaries, pulmonary vein, and then the coronary circulation, which is all the blood, oxygen, and nutrients to the heart muscle itself. So when we start talking about vascular resistance, this is systemic vascular resistance, which is what that left side of the heart is pumping against to pump the blood out. You have PVR, or pulmonary vascular resistance, is what the right side of the heart has to pump against into the pulmonary system. Heart sounds. Your first heart sound is the closure of the atrioventricular valves. Those are the valves between the atrium and the ventricle. On the right side, that's your tricuspid valve. On the left side, that's your pulmonic valve. Those closures make your first heart sound, or your S1. Your second heart sound, or your S2, is the closure of your semilunar valves. Your semilunar valves are the ones that pump from your ventricles into your pulmonary vein and pulmonary vein and your pulmonary artery and aorta. So your pulmonary valve and your aortic valve into your pulmonary artery and your aorta. Here we go. Heart murmurs are when there's a disturbance or disruption in the flow, usually through the valves. Friction rub is an inflammation in the sac, the pericardial sac surrounding the heart. Okay, that's good. Just another slide talking about the heart sounds. The S3 gallop happens at the beginning of diastole. It occurs when the blood in the left ventricle, when blood flow into the ventricles during the opening of the atrioventricular valves causes vibrations. It's a ventricular gallop. Often will be found when with a fluid overload, like here it says a dilated ventricle. Kentucky, 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 Kentucky. Kentucky, Kentucky sounds very, very close to the second heart sound. Your S4 occurs late in diastole due to the atrial contraction and injection of blood into the ventricles. So when those atrial chambers are squeezing the blood into the ventricles, you can get an S4, which usually, because the ventricle itself is very, very stiff. That heart sound comes right before the S1. Tennessee, 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 Tennessee. It's almost like your first sound is almost split. Your cardiac cycle, the atrium fills passively. It just lets itself fill. They squeeze when the atrioventricular valves, which are your tricuspid on the right and your mitral on the left, open. Hang on. The atriums, both the right and left atrium, fill up. When they're full, your atrioventricular valves, which is your tricuspid on the right, mitral on the left, those open. When the atrium contracts, those valves open and the blood goes into the ventricles, and the ventricles to fill the ventricles. Those valves close, and when the ventricles contract, both ventricles contract, your aortic valve and pulmonic valve, pulmonic going into the pulmonary blood flow, aortic going to the systemic blood flow, those open when the ventricles contract and the blood pumps out. A cardiac cycle is the whole one heartbeat, contraction and relaxation of the entire heart. Pulse volume is the force of blood with each beat. And a pulse deficit is when there's a little delay in feeling the perfusion, the radial pulse, when you're listening to the apical. I changed the order in these just a little bit. That made a little more sense. This is just more about your diastole and systole. I talk about this a lot with your heart failure and your cardiomyopathy. I have to remember it by thinking of your blood pressure, your systolic being your high number, diastolic being your low number. Don't worry about here so much with the atrial. Focus on your ventricular, because it's the main ones that affect everything. So when you think of ventricular systole, that is when your ventricles contract and the blood pumps out to your body. That's your high number, because there's high pressure in all your arteries as the blood is pumping out. Ventricular diastole is when the ventricles relax and the blood is coming from the atriums into the ventricles. cardiac output. Let's see, your cardiac output is how much blood your heart pumps out with each heartbeat. How many mils, I guess you could say. It's mils, I'm not per heartbeat, per minute. Stroke volume is mils per heartbeat. Cardiac output is mils per minute. So if you combine your heart rate, how many beats per minute times how many mils per beat, that's how you get your cardiac output. There is a little video I had posted for preload and afterload for you to look at. Preload is the amount of cardiac muscle fiber tension or stretch existing at the end of diastole. That's when your ventricles, I said we always focus on your ventricles, so preload is how much tension there is on those muscles when the ventricles are filling. I briefly mentioned this already. Your pulmonary and systemic vascular resistance. This is where your afterload comes in. How much force that ventricle has to pump against is your afterload. So preload is the amount of tension in those muscle fibers when the ventricles are filling. Afterload is how much resistance it has to go against. And so when we talk about cardiomyopathy, heart failure, coronary artery disease, all these things, your medications, they all are affecting our preload, afterload, pulmonary vascular resistance, systemic vascular resistance. These are terms that you will see throughout the cardiac material. Here's your cardiac output again. And again, because I messed up, your cardiac output is how many mils of blood is pumped out per minute. So if you take your cardiac heart rate, beats per minute, times your stroke volume, which is mils per minute, together equal your cardiac output. In heart failure and cardiomyopathy, we talk a lot about these pressures and Starling's law. As the ventricle stretches out, it's like a slingshot. The more it stretches out, the more forceful the pressure will be when it ejects. Normal ejection fraction, which I mentioned in other lectures, is 50 to 70. It is percentage of volume that is ejected during systole. So you have your stroke volume, which is your mils that are ejected, and your cardiac output is percentage of blood. Compliance is the ability of the arteries to contract and expand. Contractility is the cardiac muscles being able to shorten to contract. Cardiac conduction system, I'm going to cover some, I think I go into it more in this dysrhythmia. Anyway, you have your sinus node, which is our natural pacemaker. It sits in the right atrium. It sends the impulse through the right and left atriums to cause contraction. That impulse goes to the atrioventricular node, or AV node, which is in between the atrium and the ventricles. AV node. AV node sends the impulse right down through the bundles. We call them the bundle branches. There's the left branch, the right branch. They branch off into these Purkinje fibers, which is important when we start talking about dysrhythmias. Here's our electrical current. Atrial depolarization, which is just a little tiny blip, your P wave. It should take a certain amount of time for the SA node to send this impulse to the AV node. That is your PR, what you call your PR interval. Even though, see, you measure it just before your Q wave, but we call it your PR interval. So then you have your QR QRS, which is when your ventricles are depolarizing or filling. So your PR, the atriums are filling. No. Atriums are contracting during atrial depolarization. Ventricles are contracting during ventricular depolarization. So here you have your P wave because the SA node sends an impulse to the AV node. When it sends an impulse through this chamber, it makes this contract and the blood goes into your ventricles. This impulse comes through all these fibers, through your bundles, bundle of His, your right bundle, your left bundle, down into your Purkinje fibers to get all of this to contract and the blood to come out. Little blip for your PR interval is because the atrial contraction is not real strong. Ventricular contraction is very strong. You see your QRS. Repolarization is when that T wave is getting ready. It's called a refractory period, when they resist stimulation. If you have an extra beat falling, you don't want it to fall too close to that T wave when it starts to get where it can send them into a bad rhythm. Okay. I want you to remember here your normal rate for normal sinus rhythm is 60 to 100 beats per minute. PR interval, I know it says 0.12, but I want you to know 0.10 to 0.20. And QRS is really 0.04 to 0.12, 0.04 to 0.12. So that's the amount of time it's taking the impulses to get through. Remember, this is a big square. You see big, thick lines. There's 1, 2, 3, 4, 5 little squares inside one big square. One big square equals 0.20 seconds. Each little square is 0.04. So there's 1, 2, 3, 4, 5. 5 times 0.04 is 0.20 seconds. This is your isoelectric line. It's like you can draw a line that gets your baseline. Everything should come back to baseline as it's going along. For a 6-second strip, you have 15 of these large squares. If you have a 6-second strip, you can calculate your heart rate with 30 large squares times 10, and that will give you a heart rate. I am not going to make you do that on this test. Okay, so now we're going to get into dysrhythmias. Some terms: atrial kick. Sometimes you'll hear that word, atrial kick, the little extra bolus of blood to the ventricles before they contract. If somebody's in an atrial fib, they might affect the output a little bit because they lose their atrial kick. Cardiac rest is when the heart is not beating at all. Sudden cardiac death, unexpected death occurring with 1 hour of onset or cardiovascular symptoms. Sudden cardiac death. Within 1 hour, it's not they die right then and there, although they can. Within 1 hour of the onset of symptoms. Dysrhythmia isn't a rhythm that is abnormal. It's not necessarily a dangerous rhythm. Anything that's abnormal, including sinus tach, sinus bradyia, it is an abnormal rhythm. Ectopic is pulse sensations that come from a different odd place, not from the SA node, AV node, down the fibers. It's an impulse that is sent from someplace else, not the normal pace setters of the heart. Paroxysmal, it comes in bursts. It abruptly starts and abruptly stops. This is just some terminology. Automaticity is how the pacemaker cells, not all the cardiac cells, but the pacemaker cells can automatically initiate an electrical impulse. Excitability is how these pacemaker cells respond to stimulus. Conductivity is sending the impulse from cell to cell. Refractoriness is absolute or supernormal, where it cannot depolarize during that T wave. Okay. Ectopic beats, as I mentioned, are beats that are coming from someplace else. It may be due to ischemia, injury, infarction, which is actual tissue death. And we'll talk about that more in your CAD, coronary artery disease lecture. Your EKG rhythm, I just said that at the beginning of this lecture, so I'm going to keep going. Risk factors for dysrhythmias or history of heart disease, heart damage, electrolyte abnormalities, especially your any of your electrolytes, but mainly your potassium and magnesium, hormonal changes, deterioration of the heart structure, diabetes, especially if it leads to cardiomyopathy and the structure of the heart changes so it can cause dysrhythmias. Hyperthyroidism can lead to some dangerous dysrhythmias or even just a sinus tachycardia. Hypothyroidism can lead to bradycardia or slowing of the rhythmias. Sleep apnea leads to repeated episodes of hypoxia, so the carbon dioxide levels change and it changes the pressures in the heart, causes inflammation in the heart, and can lead to dysrhythmias. Alcohol, stimulants, certain medications. Alcohol, as you'll see when we talk about cardiomyopathy, and cardiomyopathy, the damage that alcohol intoxication can have on the heart. Stimulants can be anything from caffeine to cocaine that increase the catecholamines, which are released by stimulating the sympathetic nervous system. Preventing heart disease, maintaining a healthy lifestyle. That's your diet, your food, your exercise, your weight. Limit alcohol and tobacco. Limit your caffeine. Increased levels of caffeine or frequency of caffeine can cause some dysrhythmias, may be tachycardia, palpitations, SVT that we talk about. Supraventricular rhythms. This is everything that occurs above the ventricles. These are not ventricular rhythms. So everything above the ventricle that sends an impulse above the ventricle is a supraventricular rhythm. Okay, so dysrhythmias or abnormal rhythms that come from the sinus node are sinus bradycardia or sinus tachycardia. Bradycardia is a very slow rhythm, less than 60. Tachycardia is greater than 100. Only treated if symptomatic. So bradycardia is treated with atropine, dopamine, epinephrine, or pacemaker. We're going to talk about that some more. Tachycardia is a heart rate greater than 100. If they are symptomatic, they're treated with a beta blocker or verapamil, which is a calcium channel blocker. Sinus bradycardia. Multiple things can cause it, such as increased vagal tone. That's for the athlete, like a distance runner, swimmer. Often their heart rate is 45 to 50. They are totally asymptomatic, and this is normal for them. They have a sinus brady, but they are asymptomatic. They are perfusing fine. We're going to talk about symptoms in a minute. Then we're going to go into some different other rhythms. A sixth sinus syndrome is when your sinus is sick. It's not sending out the impulses right. They may just be in a sinus brady all the time, but they're grossly symptomatic and they will need a pacemaker. Hypothyroidism is one I mentioned, that thinking of your thyroid as being your engine. When the engine is revved down, you can have sinus brady and possibly symptomatic. Hypothermia, when the body is very, very cold, the heart rate will slow down. Hypoglycemia, there is no sugar to keep the body running, so it slows down. Obstructive sleep apnea can lead to a sinus bradycardia because there's no oxygen going through there. Initially, for sinus bradycardia, you're going to look for symptomatic, you're going to monitor, and you're going to check for their O2 sat, you're going to check their blood pressure, check their pulses, check their consciousness. You're looking for if they're symptomatic. You're going to look at medications they're on, such as beta blockers, or are they on a calcium channel blocker, such as verapamil or diltiazem? Are they on an antiarrhythmic, such as amiodarone and digoxin, which we will talk about? Some tricyclic antidepressants can cause bradycardia, and opioids. Symptoms of bradycardia. If this is a symptomatic bradycardia, lightheaded or dizziness, especially with exertion, really tired, syncope or fainting, shortness of breath, chest pain or discomfort, confusion, are all symptoms that they are not perfusing well to their tissue, to their brain, to their vital organs, and this is symptomatic and should be treated. Always check airway and breathing. Okay, and make sure the symptoms are due to the slow heart rate. Algorithm from the ACLS for your bradycardia. Understanding airway, breathing, circulation, oxygen, monitoring, get an IV site in. In a symptomatic bradycardia, you're preparing for a pacemaker. Transcutaneous pacemaker, we will talk about during this lecture. Atropine, and then epinephrine or dopamine. I'm going to talk some more about them for symptomatic bradycardia. And here's just a really good things to think of, things that can cause bradycardia, your H's and your T's. There's another bradycardia algorithm. Oxygen, airway, breathing, circulation. Get your oxygen going, keep them on a monitor, get IV access, prepare for a pacemaker, give atropine, and you might have to give epi or dopamine. Atropine is for symptomatic bradycardia. It is the first line of treatment if you do not have another cause. If you cannot find a reversible cause, like a medication you can pull off, you will give atropine. Be careful giving atropine. It is an anticholinergic. It affects the parasympathetic nervous system. If somebody has ischemia or poor heart blood flow through the coronary arteries, and you put atropine in, increase the oxygen demand on their heart, you can actually worsen the ischemia or initiate or worsen the myocardial infarction. So you give IV every 3 to 5 minutes for a max of 6 doses. Atropine does not work on second and third degree heart blocks because there is a blockage. So it doesn't matter how much you stimulate that sinus node. If that impulse cannot get through because of a heart block, then it's not going to work. Dopamine is a drug that might be used. It's a second line for symptomatic bradycardia. If your atropine is not effective, it's given in an IV and continuous infusion. It has different doses depending on what it's needed for. The very low dose for renal vasodilation, 5 to 10 is normally where you'll see it, because when you get above 10, it changes and it becomes very vasoconstrictive. Epinephrine can be used as an equal or alternative to dopamine when your atropine is not effective. It's also given in a continuous infusion. Sometimes it's given as an injection, but it's always given intravenously. Non-selective adrenergic agonist. Again, just like your dopamine, the low dose will increase your heart rate, but high doses will cause a vasoconstriction. Epinephrine, we will see more for increasing blood pressure when we talk about shock in the next modules. Epinephrine is not in your initial line of treatment for your pediatric population. Okay, let me keep going. That's all I need to say there. Sinus, oh yeah, I stuck in the sinus tachycardia. I emailed this to you. I didn't print it off myself. Anyway, I emailed this to you because I realized I didn't actually do a slide. I did touch on the sinus tach a few slides ago, and I went into sinus bradycardia, so I added one in for your sinus tachycardia. All characteristics of the normal sinus rhythm except your heart rate is greater than 100. Your PRQS, all those things are normal, just your rate is faster than 100 beats per minute. It can be a response to internal change. It's response to internal changes, exercise, anxiety, pain, fever, hypoxia, hypovolemia, hyperthyroidism, and there is a question on this. Sinus arrhythmia just is benign. It is an arrhythmia. You still have a normal PRQRST. It's just your rate goes faster and slower with your breathing. It increases with inspiration. It decreases with expiration. It's found commonly in the very young. I've seen it through 20s and in the elderly. PAC is a premature atrial contraction. You can see that your P wave looks a little different than that P wave. That P wave there, that all look the same. That P wave looks like that one. If you plot it out, if you were to take something and plot, then this one comes a little early and this one comes a little early. So you have your normal sinus rhythm, just occasionally you have an atrial contraction that comes a little early. Usually it's an irritant such as caffeine, stress, nicotine. Ask the person, how much caffeine did you have? Are you on a lot of stress? Have you been drinking alcohol? How recently did you smoke? If it's so frequent, it needs to be managed after you remove the irritants such as the caffeine, stress, nicotine. They maybe have to be treated with the beta blocker, possibly a calcium channel blocker such as verapamil. Just reminders of your beta blockers, your allols. NSAIDs reduce the effect of them. Never stop beta blockers abruptly. Be careful in diabetics because beta blockers can mask hypoglycemic symptoms. Careful with using beta blockers in congestive heart failure because the beta blockers will relax that muscle and may worsen congestive heart failure. For years we did not use beta blockers with heart failure, but did find that it can be helpful in certain rhythms. So carvedilol, if you use a beta blocker in congestive heart failure, usually it's carvedilol. What else do you need to know on beta blockers? Hold if your heart rate is less than 60. Monitor your blood pressure. You want to make sure your systolic is greater than 90. Wheezing. Caution using beta blockers in people with asthma, COPD, some kind of bronchoconstrictive disease if it's a non-selective, meaning that it affects the beta 1 and the beta 2 cells. The beta 1 selectives are atenolol, metoprolol and Nebivol. Sorry, I'm tired and my tongue's tied. Okay, calcium channel blockers, which are used for atrial arrhythmias or dysrhythmias. You have your dipines and you have your divers. Several of the things we will be discussing, diltiazem and verapamil will come up quite often. So here's your verapamil, a calcium channel blocker that inhibits the calcium across the cardiac vascular smooth muscles, dilates the cardiac and peripheral arteries. That is why it is used for so many things in coronary artery disease. Does interact with your beta blockers. If you give a calcium channel blocker and a beta blocker, or calcium channel blocker and verapamil, which is a calcium channel blocker, together, the combination can worsen the decrease in the heart rate. So you have to be careful and watch for that. If given with statins for your cholesterol, you have an increased chance of myalgias and rhabdomyolysis, which is the destruction of the muscle. Grapefruit juice, if given with verapamil, increases the concentration of verapamil in the body. What is verapamil used for? What rhythms? Premature atrial contractions when they're frequent and need to be managed. In hypertension, as I mentioned, often used in coronary artery disease, and it may be used in atrial fib to dilate that, help with perfusion. Paroxysmal supraventricular tachycardia. Do not confuse this with ventricular tachycardia. This is occurring above the ventricle, often referred to as PSVT, paroxysmal. It comes, they have a burst, it goes away. Paroxysmal supraventricular tachycardia. Some people can go into just a plain supraventricular tachycardia, not paroxysmal. It doesn't come and go. They suddenly go into this rapid rhythm that has the same deflection as the others. It's going in the same direction. You can tell it's not wide and bizarre, so it's not going through the ventricles, but it is very, very rapid, usually between 140 and 250. Very, very rapid supraventricular arrhythmia. So it can be PSVT or an SVT. You treat them if they're symptomatic. If they're in a maintained SVT, not paroxysmal, you definitely have to treat. First thing you try is ask them to bear down, do the Valsalva maneuver, give them oxygen, and the medications, adenosine, a beta blocker, calcium channel blocker, possibly a pacemaker, synchronized cardioversion. We will talk about pacers and cardioversion, and the next slide talks about your adenosine. When adenosine is used to cardiovert, it's a drug cardioversion instead of a synchronized cardioversion. It means to convert them back into a regular rhythm. So it can be used to cardiovert this abnormal rhythm. And as I mentioned when I talked about, I'm going to get into, adenosine here. It is an antiarrhythmic. Don't worry about which class it is. It can be diagnostic. It can be used to treat paroxysmal supraventricular tachycardia or just an SVT and a Wolff-Parkinson-White syndrome, which I'm not going to go into, the WPW syndrome. It slows the impulse from the SA node and conduction time through the AV node. What it's trying to do is get things to slow down and let the heart, normal pacemaker, kick back in. It's given IV push very, very rapidly. It has a half-life of less than 30 seconds. That is why you push this so fast. Side effects can be facial flushing, headache, chest pressure, but it's very, very brief. They might go into asystole or transient heart block. It is transient. It goes away. You see this block right here and the asystole. They go into it and they stop. You look in here when the adenosine was given here. It takes, let's see, 2, 3, 4, 5, 6. 6 times 0.20, because there's 0.2 seconds in a big square, so roughly just 1 minute. 20, 40, 60, yeah, about 1 minute time span here. So you've got a couple of minutes here when it's kicked in and kicks back in. These are just some PVCs, what we used to call it friendly PVCs. Anyway, that's enough on adenosine. Now, let's start talking about atrial fibrillation. Electrical activity in the atrium is disorganized. Here's a picture. The next slide, I changed out the atrial fib to give you a better picture of it. Your atrial fib, you have your QRS and T are normal. You can't really see it on here. It's better on the next slide. Your atrium is fibrillating. It is an irregular rhythm. See, the atrial quivers, the blood may pool, and it can form clots, making it very dangerous. Your atrial rate is much greater than your ventricular rate. Not very many of these impulses are getting through. Here's a better picture of atrial fib where there's no rhyme or reason to that. Atrium is just quivering, 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 and your QRS. So the atrium sends 1 million impulses from all kinds of pacer sites throughout that atrium, and then one gets through and the ventricle contracts. You can tell it's coming from the atrium because your QRS is not wide and bizarre, so this is above the ventricle rhythm, is not a ventricular rhythm. Several drugs can be used. Metoprolol and cardizem are both, metoprolol is a beta blocker, cardizem is a calcium channel blocker. Some antiarrhythmics may be used. Digoxin is not used as often as it used to be because they're finding problems with it. Often if somebody is chronically in atrial fib, they will put them on anticoagulants. The purpose of anticoagulants is because in the fib, that blood is pooling, so they have a good chance of forming clots. And any one of these impulses that goes through the QRS, that clot can go anywhere into, if it's on the right side of the heart, it'll go into the lungs, cause a pulmonary embolus. Left side of the heart, it can go to the coronary arteries and cause a heart attack. It can go out into the periphery to the brain and cause a stroke, into the kidney and shut the kidneys down into the body, and be an occlusion anywhere in any of the arteries. Synchronized cardioversion, we will talk about that. In ablation, we will talk about where they burn those places to stop the crazy impulses from going through. Digoxin is the only glycoside that we use. It's used in atrial fib, atrial flutter, sometimes used in congestive heart failure, not quite as often as it used to be. Very much have to watch the kidneys and the electrolytes. When somebody's on a diuretic like Lasix, or which is a loop diuretic, even hydrochlorothiazide, since even though it's not a loop diuretic, it is not potassium sparing. You have to watch your potassium when you're on digoxin. If the potassium is low, below 3.5, it increases the risk of having dig toxicity. Digoxin has a very, very low, narrow therapeutic window. So you want your levels between 0.8 and 2. I would focus on the high end of the 2. Above 2 is dig toxicity. They can have dysrhythmias. They can go into VTAC, VFib. Abdominal pain is a late sign, but you'll see nausea. Some halos, yellow halos around the eyes. That they're saying they're seeing yellow halos when they're looking at things. Digitoxicity can also lead to bradycardia. There's just a little note on there on foods that are high in potassium are banana, spinach, potatoes. Salt substitutes, orange citrus, nuts, and grapefruit. So be monitoring your kidney function and your potassium levels. Here's another little picture somebody did when we used only digoxin on our hearts. Check your potassium levels before you fill up. Don't give us the heart rate's less than 60. Digitoxicity, this is incorrect. It's greater than 2. Okay, that should be it on that slide. Let's talk about atrial flutter. Atrial flutter, unlike atrial fib, atrial flutter is a regular, irregular rhythm. There is a pattern to it. I will have you identify different rhythms. I'm not going to go into saying is it a 2-to-1 flutter or a 3-to-1 flutter, just if you can recognize the rhythms. I was very nice on the test. So this is some sort of atrioventricular block because the impulse is, of course, going several times in the atrium before it gets through the ventricle. It is treated with beta blockers or calcium channel blocker like verapamil, sometimes antidysrhythmics, again anticoagulants because of the clotting of the blood and the risk for clots. Some people live in atrial fib, but you cannot stay in atrial flutter. It is a more significant block, and they will use drugs to get them out or do a synchronized cardioversion. Common antidysrhythmics that are used in atrial flutter are procainamide, lidocaine, and flecainide. Okay, so we're going to talk about oral anticoagulants. We have talked about these before. So we're going to touch on them again. Your warfarin is your Coumadin oral anticoagulant. There's the direct thrombin inhibitors and there's the XA inhibitors, and I'm going to break that down a little more here for which ones I want you to focus on. Apixaban or Eliquis. Oh, this slide's kind of messed up. It is an XA inhibitor. It blocks the production of fibrin to decrease the risk of stroke and systemic emboli, especially in the patient that is in an atrial fib or atrial flutter. So it affects way down in the XA factor in the clotting cascade. It inhibits the clot-induced platelet aggregation. Some interactions with ketoconazole, phenytoin and carbamazepine are both anti-seizure meds, antivirals. Let me see. The effects or the levels of your apixaban are increased with anti-seizure drugs, ketoconazole, antivirals, NSAIDs, antiplatelets such as can't think of it, clopidogrel. St. John's wort decreases the effect of your Eliquis. You want to monitor your CBC, your CMP, and your kidney and liver function on Eliquis. Esmolol or Brevibloc, it's a selective beta-1 blocker, beta blocker. It's used in SVT, atrial fib, and atrial flutter to slow the sinus rate. Increased effects when given with calcium channel blockers. That's any of the beta blockers. This is given in an IV infusion. You need to closely monitor that apical heart rate and blood pressure. Hold if the heart rate's less than 60, systolic blood pressure less than 90, which if you've noticed on any of these drugs, that's the parameters on anything that's going to slow down, lower the blood pressure, slower the heart rate. It can cause profound hypotension and bradycardia, and like any beta blocker, hypoglycemia can be masked in the diabetic. Junctional escape rhythm. So I got this turned around here. Okay. A junctional escape rhythm is an advanced AV junction you don't see any P. It's kind of wide, but not real bizarre QRS, so it's still coming from just above. It's in the junction between the atrium and the ventricle, and because it has a kind of odd root is why you might see this flipped over. Just knowing junctional escape rhythm is usually due to digitoxicity. You need to give Digibond or something to pull that dig off of there. Hold your dig. The rate's usually 40 to 60. There is no P wave, but you see there is a QRS, but it's coming in that junction. Digitoxicity. Okay, ventricular rhythms. Because these are anything coming from below the junction, below the AV junction. Premature ventricular contraction, like the premature atrial contraction, it comes early in the rhythm, but this is wide and bizarre, coming from the ventricle, so it's going a whole different route. Wide and bizarre. Look how wide that thing is. Very odd looking, usually opposite deflection than your rest of your heartbeat. PVCs often caused by stimulants such as cocaine or excessive caffeine. Treated with, if withdrawing the irritant, if needed, you can use beta blockers or antiarrhythmics if the person is very symptomatic or significant heart disease. You can have a PVC by itself. If there's two, it's a couplet. If there's three in a row, it's a triplet. Sometimes it comes, we don't have enough of this to see, every other beat would be a bigeminy, every third beat's a trigeminy. They can come all from the same place, unifocal. If you have a PVC over here and it looks very different, but it's definitely wide and bizarre, it's coming from more than one place, more than one focus. It's called multifocal. VTAC, ventricular tachycardia. It's a rapid ventricular rhythm. You don't see any P, it's just only ventricular activity. There is no atrial activity here. It is wide and bizarre. The rate is greater than 100 beats per minute. This first one is somewhere above 150 or about 150. This one is even faster than that. But these are both examples of ventricular tachycardia. It is a very regular rhythm with no P waves. QRS is wide and bizarre, but the rhythm is greater than 100. They may go in and come out of this. If they sustain it, you need to treat them. You may give an antiarrhythmic if they're unstable, cardiovert them, which we'll talk about, surgical ablation if there's somewhere in that ventricle that keeps doing it. They may implant an internal cardiac defibrillator. Pulseless VTAC is treated as VFib. Pulseless VTAC is treated as ventricular fibrillation. Ventricular fibrillation is always pulseless, and we're going to talk a little more about ventricular fibrillation. But VTAC is an emergency. You have to get them out of this, because if you don't get them out of this, they are going to deteriorate into a VFib. So it is definitely a medical emergency. Antiarrhythmics. If they have no structural heart damage, you can give flecainide, propafenone. These slow the conduction velocity, but does not affect repolarization. So it's not going to be like your adenosine or something that's just going to stop the impulses from going through. Side effects: dizziness, metallic taste, bradycardia, heart block, GI upset, heart failure. Flecainide can affect your white blood cells, propafenone, bronchospasm. So obviously you would not give the propafenone with somebody with asthma. The way I would remember that one is it looks a lot like propranolol, which is a beta blocker, non-selective beta blocker that you would avoid with bronchospasms. Propafenone sounds a lot like propranolol. That's how I remember it. So when I say you can give this if they do not have any structural structural heart damage is heart failure, coronary artery disease, hypertrophic cardiomyopathy, and congenital heart disease. Amiodarone. My papers are in the wrong order. Amiodarone. It is an antiarrhythmic used in life-threatening VFib and VTAC. VFib and VTAC are both life-threatening. You can use amiodarone only after anything else fails, because there's a lot of problems with amiodarone. Potentially fatal pulmonary toxicity in ARDS. Because of this, it is not used as frequently, only if everything else fails. It blocks the calcium, sodium, and potassium channels in the heart so that the impulses don't go through. And so there's a refractory period where the impulses can't hit on there, the ventricular impulses can't go through. Closely monitor the EKG and their liver enzymes. Never give this with grapefruit. It can prolong the QT interval, which can lead to other problems. It is extensively metabolized in the liver and excreted in the bile. It doesn't go anywhere near the kidneys, so monitor those liver enzymes. Monitor their EKG for that prolonged PR, QT, and widening QRS, because it's blocking all those channels. Adenosine versus amiodarone is a slide I found that you might find a little helpful in looking over things. Ventricular fibrillation, immediate defibrillation. This is a medical emergency. Check to make sure if it is true VFib, they are pulseless. They will have no pulse. The ventricles are simply quivering and chaotic and bizarre. It's not a regular rhythm like this, like VTAC. It is chaotic, irregular, not a regular rhythm. This will lead to sudden cardiac death. It needs to be addressed right away. Remember, sudden cardiac death is death that occurs within an hour of the onset of symptoms. So if you go into VFib, there is no oxygen perfusing, so the heart is getting ischemic, it's spreading, they are pulseless, nothing is perfusing. They will advance or deteriorate to asystole and can lead to sudden cardiac death. Lidocaine is an antiarrhythmic. It very rapidly gets control of ventricular rhythms, especially following a myocardial infarction, surgery, and cardiac cath. It suppresses that automaticity. increases electrical stimulation threshold in the ventricle, meaning that it's not so easy for the ventricle to send out that impulse of a ventricular beat. It is given IV push. It can be given also in a continuous infusion following the push. Always have your resuscitate equipment available, be ready for a code. Monitor for toxicity through changes in the vision, respiratory distress, changes in level of consciousness. Usually you'll see confusion, a prolonged QT, prolonged PR, just like you saw in your amiodarone. Torsades. This is a type of VTAC. A type of VTAC. It's kind of a bizarre VTAC where you notice there is VTAC that's very regular. There's VFib that's just a fibrillation of the ventricle. The torsades is a rhythm like a party streamer, often due to cocaine, myocardial infarction, or common causes, or medications such as like lidocaine and amiodarone that can prolong the QT might cause somebody to go into a torsades. They will have palpitation, syncope, and dizziness because it is a type of VTAC. They can have a pulse with it, but it can lead to VFib and sudden cardiac death. Your typical antiarrhythmics can actually aggravate this, so you will, for a torsades, you need to recognize it because you will not do amiodarone or your lidocaine for this. You can make it worse. So this torsades is treated with isoprel, atropine, usually magnesium. The newest standards are giving magnesium infusion. A continuous infusion is the best treatment for torsades, which is a type of VTAC with a long, often due to a prolonged QT interval. Here's your treatment of torsades, and as I said, the magnesium is the most, if you look at your ACLS, American Heart Association is now saying to treat it with a magnesium infusion 1 milligram per hour. Isoprel, if it's needed, it's a non-selective beta agonist. It lowers the pulmonary vascular resistance. It will cause a drop in blood pressure. It causes a inotropic and chronotropic effect, which helps the heart kind of squeeze a little better, increasing the cardiac output. More information on your isoprel. As I said, a non-selective beta agonist can cause the heart to squeeze a little better. It decreases the pulmonary vascular resistance. It's used in heart block that doesn't require a pacemaker. Okay, I think that's all I need to tell you. It's given in IV bolus followed by an infusion. Atrioventricular conduction blocks. So these are occurring in the atrium, different degrees of block. First degree heart block is the PR is greater than 0.20. The time is taken that atrium, the sinus node, to send the impulse to the AV node to your PR interval is greater than 0.20. Usually you try to find out what's causing it and get rid of it. You will have no symptoms to it, and you don't do anything other than monitor it. Second degree type 1. The PR gets longer, drop, winky, bach. I kept saying that in class and nobody was catching on to what I was saying when you're trying to figure out if it's second degree type 1 or second degree type 2. Second degree type 1 is winky bach, longer drop. Your PR interval here is 0.20. Then here it's like 0.24, and then we'll say 0.40. So it's longer. You have a PR is normal, then it's longer, then it's even longer, and then you have a PA, no QRS. PR, longer. So we go long, longer, longer, drop. Normal, long, longer, longer, drop. Winky, Bach. Second degree, type 1 Winky Bach. It's a repeating pattern where an increasing AV conduction, usually it comes and goes. Rare that this one will progress onto anything else. Rare, rare. Second degree, type 2 will progress to a third degree. Second degree, type 2. So you have no warning. You have a normal PR, and all of a sudden you have a PR with no QRS. Normal PR, normal PR, normal PR, you have a P wave, no QRS. There is no warning. Second degree, type 2. You have drops with no warning, which will progress to a third degree heart block. You want to treat it with atropine or isoprel, and you want to prepare for a pacemaker. Third degree, type 2, is a complete heart block, what we used to call an AV dissociation. The atrium and the ventricle are not talking to each other at all. They are completely disassociated. So you have P waves that march out. Here, 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 here. This P wave, no way, conducted that QRS. So if you took your calipers or a piece of paper, they would plot to fall at the same exact point. They're the same distance because the atrium is doing its own squeezing and the ventricle's doing its own thing. They are completely divorced. This is a wide QRS. So it's wide and bizarre, so it's coming from someplace other than the atrium. So you have your QRS will plot out, and then your P waves will plot out. You got a P wave lost in that QRS. Okay. Constant PR interval. P waves are not always followed by a QRS. A pacemaker is needed. Okay. You have many more P waves than you do QRSs. Defibrillation or cardioversion. You can only defibrillate, take them out of fibrillation if they're in fibrillation. So defibrillation is used for a ventricular fibrillation or pulseless VTAC, which is treated as ventricular fibrillation. Cardioversion is when you want to take the heart out of a rhythm. You want to convert their rhythm. It's cardioversion. It's synchronized. You put it on and you set it to synchronized, and the machine senses the rhythm and it picks the point to kick in to try to get them into a stable rhythm. You'll use this like they may do it with atrial fib. They'll do it for atrial flutter. They'll do it for VTAC that has a pulse and the person usually is with it. They're going to synchronize it. That's about all you need to know at this point for those two. Here's your cardioversion and your defibrillation. Remember, cardioversion is planned, so you have to get an informed consent. It is elective. It's not done in an emergency. You sedate them and you synchronize it. Get a consent. Keep them on a cardiac monitor. Defibrillation is an emergency. It's when they're pulseless, VTAC or VFib. VFib is always pulseless. It is an emergency. They have no cardiac output. They are not perfusing. They're unconscious. You have to call a code and shock. That's when they talk about shocking them. Nurses roll in the synchronized cardioversion. This is the plan. You get them ready, explain the procedure, make sure labs are all there. Definitely want to watch your electrolytes before you go cardioverting them. Get everything ready. There is a high risk for thromboembolism because if they're in an atrial fib or an atrial flutter, the blood is pooled there. So a lot of times what they'll do is a TEE, transesophageal echo, or something to look for those clots, or put them on an anticoagulant, whether it's Eliquis or Coumadin or even heparin, something ahead of time to decrease the risk of having those clots and shoving them through there. There's always that risk of having a stroke or an emboli thrown from this procedure. Temporary pacemaker. It is a pacemaker that is pacing from outside the body. It can be done transvenous through a vein, and it can be done transcutaneous through the skin, and epicardial through wires. This is transcutaneous. You will have it on your code cards. They have pads like your defibrillator pads that you put on, and you have to pace them through the skin. It takes a lot of energy. You have to put the joules up pretty high to get it to go through, but you use it in an emergency to try to get some rhythm and cardiac output to perfuse. Transvenous pacemaker goes through a wire. That can also be done in an emergency where they stick in, usually like this picture shows it in the jugular. They can stick a jugular catheter in and send the wire through there and try to pace them that way. The pacer wires have to go into the right side of the heart and pace. These are temporary solutions till you can get a permanent pacemaker. Epicardial pacing, this you will find a patient, usually the only time I've seen him is after open heart surgery, where you see the staples here. They have wires that stay for a certain period of time after their surgery, and that way if they go into a rhythm that you have this, no, I don't have a picture of it, do I? There's a pacemaker box that you have batteries in. You hook the wires to it and increase things to pick up and cause a conduction. A permanent pacemaker can be done transvenously, going through the vein, or epicardial, with this, which is done surgically. This is done through the subclavian, and this is done surgically. A pulse generator is implanted, stays in the body under the skin. They have leads that can go into the atrium or the ventricle or both. So it can be atrially paced, that's a single atrially, or ventricularly paced, that's called a single chamber pacing. Or it can pace both the atrium and the ventricle, called a dual chamber pacemaker. Here's some pictures. Single chamber pacemaker. You see a little spike, that's for it's pacing your atrium. The picture I have for your test, it's much clearer, where you can see the little spike in your P wave. This is ventricularly paced. You don't see any P wave, you just see a spike right next to your QRS. This is AV paced. You see an atrial spike, a ventricular spike, an atrial spike, a ventricular spike. This is a failure to capture. Here, there's nothing there. You see the spike and a beat, a spike and a beat, a spike and a beat, a spike and nothing, a spike and nothing. It means that it failed to capture, the impulse didn't go through, and the heart did not, it missed that beat. Permanent pacemaker discharge instructions. They need to have a medical alert, an ID saying they have a pacemaker. They want to report if that pulse rate is about 5 below what it's set to do. Keep cell phones 6 inches away from the generator. Usually a generator is sitting up in that chest, and like a man, you don't want them carrying their phone in that shirt pocket near that pacemaker. Avoid strong magnets, avoid leaning over motor engines. They need to tell people they have a pacemaker before any procedures are done. And don't get close to auto theft devices. Implantable cardio defibrillator, an ACD, an automatic cardiac defibrillator that gets implanted also under the skin. It's put in surgery, and they now have often what they'll have is a combination of a defibrillator and a pacemaker, so it can do both. I don't think I mentioned when I talk about pacemakers can be demand, where they kick in when the heart rate gets below a certain point, or kicks in if the heart rate gets too fast to knock it down and the pacer takes over. Anyway, defibrillator is there in electrodes in the atrium and the ventricle, so if the person goes into an atrial fib, it will it will shock the heart. It will defibrillate automatically. And patients that have it say it feels like they actually feel like a punch to the chest when it kicks in. Ablation, when they look in, they can do it in the atrium and in the ventricle for different arrhythmias. They go in and find what they call hot spots, and they burn them or ablate them to prevent those crazy impulses from coming through. Dysrhythmias in older adults, they may experience them even without any heart disease. They have a higher chance of having arrhythmias that lead to bad consequences. They cannot tolerate them. Common to have extra beats with exercise. Assessment should focus on effects of dysrhythmia on functional health status, and you want to teach risk reduction. 1 in 9 men will experience sudden cardiac death before the age of 70. Sudden cardiac death is death within 1 hour onset of symptoms. Cardiac arrest is cessation of heart function. Coronary heart disease causes 75% of all sudden cardiac deaths in the United States. Risk factors, as with so many things, are your smoking, obesity, hypertension, diabetes, sedentary lifestyle, high-fat diet. It's all about prevention, prevention, prevention. Symptoms of sudden cardiac death: severe chest pain, dyspnea, orthopnea, palpitations, and lightheadedness. Your goals for managing sudden cardiac death: oxygenation, cardiac output, monitor care after discharge, airway, breathing, circulation, education, teaching them about their medications, teaching about follow-up, teaching about symptoms, teaching about improving their health. You want to assess and cardiac output. Remember, your cardiac output shows through your rhythm, through your mentation, through your pulses. You want to teach them about the Valsalva maneuver to help them get out of that rhythm. Or a nurse's role here: monitoring your EKG, instructing on Valsalva, assist with cardioversion, transferring to critical care, keeping the family updated and everything, monitoring electrolytes, drug levels, administering dysrhythmic medications when ordered and warranted. And that is the end of this recording.